Good day, everyone. My name is C.B. Mamrell, and on behalf of the Systems for Action National Coordinating Center here at the University of Kentucky, I'd like to welcome everyone for joining us today's Research in Progress webinar series on health equity. And for today, our topic will be, Are we measuring up? Exploring public health performance and health equity in the United States and Canada. And without further ado, I am pleased to present or introduce to you our presenter for today, Phuc, who is a third-year doctoral student in the Social Dimensions of Health program at the University of Victoria. Pho has a strong interest in public health services and systems research, and she is a research fellow in the Equity Lens and Public Health program of research at the University of Victoria. Pho's research focuses on public health performance and exploring priorities and strategies of health equity in British Columbia. She has received several research and leadership awards, including a 2015 to 2016 Fulbright Scholarship, an Academy Health Public Health Systems Research Student Scholarship, an Ontario Graduate Scholarship, and the Ida Marietta Houston Graduate Scholarship. And for the last 8 or 9 months, she's also been doing some research here at the center too as well. And so we're pleased to have her present today. And with that, Pho, I'd like to turn it over to you.
Thank you, CB, for the kind introduction, and to everyone who have logged on to this webinar. I will be presenting my Fulbright work entitled, Are We Measuring Up? Exploring Public Health Performance and Health Equity in the United States and Canada. The agenda for today is first the introduction, followed by the theoretical framework and the relevant constructs that were used for the specific project, the data sets that were used, the NLSPHS survey questions selected, along with the independent variables that were selected, research questions, data analysis, preliminary results, limitations of the study, and the next steps. This project stems from a Fulbright grant that I received and have been working on for the past 8 to 9 months here at the Systems for Action team at the University of Kentucky. The main objective of the study is to explore how accountability structures influence core public health activities, as well as how those performance activities influence health equity. The theoretical framework used for the study was influenced by the work of Dan Schroeder on the Consolidated Framework for Implementation Research, which I'll refer to as CFIR. Dr. Margie McDonald and her team have adapted the CFIR framework into a public health context. From Dan Schroeder and McDonald's work, I selected the constructs that were most relevant to my project. And this is the theoretical framework that was used for the study. The relevant CFIR constructs were in 4 domains: outer setting, community, inner setting, and implementation process. Outer setting included community or population needs and strategy and cosmopolitanism constructs. Community or population needs and strategy is the extent to which community and population needs, as well as the barriers and facilitators to meet those needs, are accurately known and prioritized. Cosmopolitanism is the degree to which an organization is networked with other external organizations. Community included characteristics of the community and characteristics of the target population constructs. Characteristics of the community are location, size, poverty, rural versus urban, deprivation index, and early development index. Characteristics of the target population includes traits such as socioeconomic status, age, sex, ethnicity, and other demographic characteristics, and aspects of location such as rural versus urban, education, income, sexual orientation, marginalized, or vulnerable groups. Inner setting included networks and communications, structural characteristics, and available resources construct. Networks and communications is the nature and quality of webs of social networks and the nature and quality of formal and informal communications within an organization. Includes coordination across departments and specialties, teamwork and team stability, relationships with others, power and authority structures. Structural characteristics are the social architecture, age, maturity, and size of an organization. It includes formalization of rules, restructuring, and governmental structures. Available resources is the level of resources dedicated for implementation and ongoing operations, including money, training, education, physical space, time, and humans. Implementation process included planning, internal implementation leaders executing and reflecting and evaluating. Planning is the degree to which a scheme or method of behavior and tasks for implementing an intervention are developed in advance and the quality of those schemes or methods. Internal implementation leaders are individuals from within the organization who have been formally appointed with responsibility for implementing an intervention as coordinator, project manager, team leader, or other similar roles. Executing is carrying out or accomplishing the implementation according to a plan. Reflecting and evaluating is the quantitative and qualitative feedback about the process and quality of implementation accompanied with regular personal and team debriefing about progress and experience. The data sets that were used for this project came from 3 sources. The first is the U.S. National Longitudinal Survey of Public Health Systems, the NLSPHS, the Area Resource File, and the National Association of County and City Health Officials, NACCHO. And all 3 data was merged into the data set that I used for my analyses. 7 NLSPHS survey questions were selected as the outcome variables for my model. 5 were health equity and 2 were public health performance. The health equity questions are: Question 9, in the past 3 years in your jurisdiction, has there been a prioritization of the community health needs that have been identified from a community needs assessment? Question 10, in the past 3 years in your jurisdiction, have community health initiatives been implemented that are consistent with priorities established from a community health needs assessment? Question 11, in the past 3 years in your jurisdiction, has a community health action plan been developed with community participation to address the community health needs? Question 12. In the past 3 years in your jurisdiction, have plans been developed to allocate resources in a manner consistent with community health action plans? And question 13. In the past 3 years in your jurisdiction, have resources been deployed as necessary to address priority health needs identified in the community health needs assessment? The public health performance questions were: Question 16. In the past 3 years in your jurisdiction, have there been regular evaluations of the effects of public health services on community health status? And question 17. In the past 3 years in your jurisdiction, have professionally recognized process and outcome measures been used to monitor public health programs and to redirect the resources as appropriate? The independent variables in all 4 waves of data are listed on the left-hand side, and they were local board of health, expenditures for the current year, number of employees, local health department FTE employees, local health department FTE nurses, local health department FTE physicians, local health department FTE nutritionists, percent of population over 65, percent of population below poverty, and percent of population with college education. The Board of Health, local health department expenditures, and employee information were from the NACCHO data. The percent of population over 65, percent of population below poverty, and percent of population with college education were from the Area Resource File. The final variables that were found to be significant and used for further testing are on the right-hand side, and they are the Board of Health exists, local health department expenditure per capita, and percent of population below poverty. Local health department expenditure per capita was a variable that I generated using the expenditure and the population variable. The 2 research questions of the study are: what factors are associated with health equity activities? And the second is: what factors are associated with public health performance activities? Data was analyzed using the random effects logistic regression. The outcome variables are from the NLSPHS survey, and they are: question 9, in the past 3 years in your jurisdiction, has there been a prioritization of the community health needs that have been identified from a community needs assessment? Question 10, in the past 3 years in your jurisdiction, have community health initiatives been implemented that are consistent with priorities established from a community health needs assessment? Question 11, in the past 3 years in your jurisdiction, has a community health action plan been developed with community participation to address community health needs? And question 12, in the past 3 years in your jurisdiction, have plans been developed to allocate resources in a manner consistent with community health action plans? Question 13, in the past 3 years in your jurisdiction, have resources been deployed as necessary to address the priority health needs identifying the community health needs assessment. Question 16, in the past 3 years in your jurisdiction, have there been regular evaluations of the effects of public health services and community health status? And question 17, in the past 3 years in your jurisdiction, have professionally recognized process and outcome measures been used to monitor public health programs and to redirect resources as appropriate? These NLSPHS variables were binary responses of yes or no. The independent variables were from the area resource file in NACCHO, the Board of Health and expenditure per capita variables were from NACCHO, and the percent of population below poverty were from the area resource file. The preliminary results for question 9 shows that having a Board of Health is statistically significant and positively associated with jurisdictions prioritizing community health needs that have been identified from the community needs assessment. Expenditure per capita is statistically significant and positively associated with jurisdictions prioritizing the community health needs that have been identified from a community needs assessment. To relate back to the theoretical framework that I mentioned at the beginning, Board of Health is in the structural characteristics construct, expenditure per capita is in the available resources construct, and the percent of population below poverty is the characteristics of the community construct. This model with an interaction term shows that the percent of population below poverty is statistically significant and negatively associated with jurisdictions prioritizing community health needs that have been identified from a community needs assessment. The interaction between expenditure per capita and percent of population below poverty is statistically significant and shows that expenditure per capita moderates the percent of population below poverty. In another model, where an interaction between having a Board of Health and expenditure per capita was found to be statistically significant, and the expenditure per capita has a larger effect in the interaction than on its own. Preliminary results for question 10 shows that having a Board of Health, expenditure per capita, and percent of population below poverty are not significant with jurisdictions that implemented community health initiatives that are consistent with priorities established from the community health needs assessment. The interaction terms that were used in the model were found also not to be significant. Preliminary results for question 11 shows that the percent of population below poverty is statistically significant and negatively associated with jurisdictions having a community health action plan developed with community participation to address community health needs. The interaction between expenditure per capita and percent of population below poverty is statistically significant, and expenditure per capita moderates the percent of population below poverty. In another model with an interaction between having a Board of Health and expenditure per capita was found to be statistically significant, where the expenditure per capita has a larger effect on the interaction than on its own. Preliminary results for question 12 shows that having a Board of Health is statistically significant and positively associated with jurisdictions that have developed plans to allocate resources in a manner consistent with community health action plans. Percent of population below poverty is statistically significant and negatively associated. The interaction between expenditure per capita and percent of population below poverty is statistically significant, with expenditure per capita moderating the percent of population below poverty. In another model with an interaction between having a Board of Health and expenditure per capita, it was found to be statistically significant, where the expenditure per capita has a larger effect on the interaction than on its own. Preliminary results for question 13 shows that the percent of population below poverty is statistically significant and negatively associated with jurisdictions that have deployed necessary resources to address priority health needs identified in the community health needs assessment. The interaction between expenditure per capita and percent of population below poverty is statistically significant, and expenditure per capita moderates the percent of population below poverty. To summarize the health equity preliminary results, the findings show having a Board of Health and the expenditure per capita is statistically significant and positively associated with jurisdictions that have prioritized community health needs, have a community health action plan, develop plans to allocate resources that are consistent with community health action plans, and have deployed necessary resources to address priority health needs. The interaction between expenditure per capita and percent of population below poverty is statistically significant for jurisdictions that prioritize community health needs, have a community health action plan, develop plans to allocate resources that are consistent with community health action plans, and have deployed necessary resources to address priority health needs. Preliminary results for questions 16 and 17 are related to public health performance. Question 16 results show that expenditure per capita is statistically significant and positively associated with jurisdictions having regular evaluations of the effects of public health services on community health status. The interaction terms were found not to be significant. Question 17 shows that the percent of population below poverty is statistically significant and negatively associated with jurisdictions that have used professionally recognized process and outcome measures to monitor public health programs and to redirect resources as appropriate. The interaction terms were found not to be significant. To summarize the public health performance preliminary results, expenditure per capita was found to be statistically significant and positively associated with jurisdictions having regular evaluations of the effects of public health services on community health status, and the percent of population below poverty is statistically significant and negatively associated with jurisdictions that have used professionally recognized process and outcome measures to monitor public health programs and to redirect the resources as appropriate. The limitations of this study is that the data obtained were from metropolitan communities and does not include public health activities in rural settings, although for the NLSPHS data set in the 2014 wave did include rural settings, just the one prior to that did not. And there were limited health equity variables that were included in all 4 waves of data. The next steps for this project is to conduct the predicted probabilities on the analyses presented to obtain the level of association for the interaction terms for the expenditure per capita, as well as the percent of population below poverty, and to see what level of association it is. And I would hope to do it in the next few days or the next week, but by the end of this month for sure. We have been in talks to adapt the NLSPHS survey to the Canadian context so we can conduct future comparisons between the U.S. and Canada, and that will be for very interesting results and a lot of learning between 2 countries. And the final results of this study will be prepared for conferences and journal submissions, and I hope to have that done by the end of this month and June as well. I would like to acknowledge the Fulbright program for funding my project, and Dr. Glenn Mays for supervising my project here. He's given me a lot of guidance, and I've learned a lot about stats. I'm a qualitative researcher by training, so been learning a lot about statistical analyses have been great and really enhances my understanding of both methodologies. I'd like to thank Dr. Marjorie McDonald and Dr. Pauly for contributing to the development of this project and for calling into the monthly calls to give the feedback and really bringing a lot of good suggestions to the project and to make it what it is today. And as well as to Lava and CD for helping me manage the data set and just figuring out the variables and all that good stuff. And of course to the Systems for Action team for taking me in as one of their family members, and I've really enjoyed my past 9 months here. By the end of the month, I will be back in Victoria to finish up my PhD. Thank you.
Thank you, Pho. And for those who are wanting to know or get more information on the NLSPHS, we have that on our website. So please do take a look at it to get more information. So before we proceed to the commentaries, I would like to first introduce them to our webinar audience. And right after the commentaries, we will open the webinar to questions from the audience. So you can type in your questions in the chat box in the lower left corner of your screen, and we'll try to get to that at the end of the webinar. So our first commentator is Dr. Bernadette Pauly, who is an associate professor in the School of Nursing and a scientist in the Center for Addictions Research of British Columbia. Bernie is a member of the Renewal of Public Systems and Services Research Collaborative and co-leads 2 studies of implementation of public health systems and services and integration of health equity in public health. Bernie is an inaugural University of Victoria Provost Community Engaged Scholar and has received national awards for her work in promoting health equity and social justice. Our second commentator will be Dr. Gabriela Alcalde, who is Vice President of Policy and Program at the Foundation for a Healthy Kentucky, where her responsibilities include implementing the Foundation's strategic plan. Gabriela leads the Foundation's health policy work and has experience in the government, nonprofit, academic, and community sectors, including qualitative research, community engagement, policy analysis and development, program development and implementation, capacity building, and advocacy. Dr. Alcalde is actively involved with boards and coalitions addressing public health policy, health equity, and communities of color. So with that, I'd like to first turn it over to you, Bernie, for your comments. Bernie, are you on the line?
I was on mute. Thank you. I was talking away.
Go ahead. We can hear you now loud and clear.
Thank you for the introduction, and it was wonderful, Phuc, to see the work in this form because we've been talking about it over a number of months, and we're very happy that you're coming back to Victoria because we have missed you while you've been in Kentucky, but glad for that experience. As was mentioned, we have a large collaborative in Canada called the Renewal of Public Health Systems and Services that in many ways, when we've talked with Glenn, it's kind of like the complement to a lot of the work that you're doing in the U.S. that, you've got your National Public Health Survey, which is really able to get at the kind of data that Phuc used. Ours is really focused on implementation. So we have very large qualitative data sets that look at what is producing particular impacts and outcomes. So when Phuc, my comments are going to basically focus on three things. One, the framework. Two, some of the proxies that were used for health equity. And then three, what we can take from this. So when Phuc identified that she wanted to focus on health equity and accountability, one of the first things that she did was to look at the national data set and the survey questions to see what could serve as proxies for health equity, because as she mentioned, there is not currently a question specific to health equity in the national longitudinal data set. But what we did is we looked at what are some of the indicators, and that's why she chose things like community needs. Was there a plan in place? And I think one of the most important ones that she pulled out was the importance of participation of communities in developing those plans and informing what kind of resources are employed. Because when you look at the health equity literature, having communities involved in making some of those determinations, particularly communities who are affected by health inequities, is particularly important. And so using that work or using that data around, the below the poverty line and what is given priority, I think I just can't overstate how striking it is to me that almost all of the findings that in the areas where the percentage of population was below poverty, the results were both significant and negatively associated with things like having a community plan, with the deployment of resources, and with the participation of those communities who would be clearly experiencing health inequities. So we hope, I think this really brings forward the fact that resource investments and the presence of public health is often not occurring where in fact it's both needed. So if we think about, public health in terms of its twin aims to have both promotion of overall population health, but also to promote health equity and reduce health inequities, for me what this really highlights in a very clear way is the mismatch between, public health, having the resources and organization, and having strong public health organizations in the actual areas and being implemented where they're most needed. And I think and again, I'm working in a Canadian context, so while I can't really, I'd love to hear how you interpret and explain folks' results, but if I think about these things in a Canadian context where we have a different kind of system in that public health is funded under our universal public health system, although marginally funded, what we find in some ways is not dissimilar, is that those areas where that are living below the poverty line often don't have the greatest strength in terms of actions around public health. And for us, some of this is really how public health has been conceptualized and implemented within a health system that's really driven by acute care, and it hasn't had the same kind of ability or attention to address some of those broader issues related to health equity. So, our hope is that we would also like to be able to create a longitudinal survey similar to the one that is so incredibly well developed and rich in that you have done in the U.S. And I think one thing that we can really add is maybe specifically looking at adding some questions that are very specific to health equity to try to get not only a better understanding but mobilize action in communities where it's needed. So thank you, and I look forward to hearing Gabriela's comments and then the discussion of the audience.
Thank you, Bernie. And Gabriela, I turn it over to you.
Thank you so much, folks. Excellent work. Really interesting. I'm really glad to have been invited. In my career, I've definitely struggled in the various organizations where I've worked to operationalize and then monitor and measure health equity. So I applaud your efforts. I think it's really important to have some sort of framework for being able to evaluate how we're operationalizing how successfully. Because I come from a qualitative research background, while you were presenting, I was very interested to see how this would look to be matched with some qualitative research, especially looking at the community experience, having community input, as well as public health professional input, and to see how those various variables that you looked at, how they would come out when explored through a qualitative lens. And also to look at what policymakers' experience and perception is of health equity being implemented in the community based on those various variables. The other things that I noted to myself were looking at health departments that had accreditation, sort of public health accreditation body. So in looking at the various boards of health to see if they are attached to a health department that has been accredited, I think that would be an important variable. The accreditation process is supposed to also go through steps that involve community engagement, community input, and to have health equity dimensions. So it would be interesting to see if there's any difference between those health departments that are accredited and those that are not. As well, in the United States, there are various types of board of health. It would be interesting to me to see what type of board of health, not just if there's one present, but is it one that has decision-making power? Is it advisory? Is it an independent board of health? For example, in Kentucky, we have various types, so you can have some that are directed from the state Department of Public Health, and we have also independent boards of health. So that would be an interesting variable to look at because they do function quite differently. I have served on a board of health, so I was very interested in, during your presentation, to think about what the composition of those boards of health were. The composition for boards of health in Kentucky is written into statute and does not actually require any public health professionals. So I'd be interested to see what the board of health composition, if there are any public health professionals that are required, as well as if there are any community representatives. The Board of Health that I served in required us to have at least 2 community representatives, and that certainly made a difference in health equity conversations and interest. So I think, again, those would be variables to look into as you further your work. And as Bernie said, just the continuing effort to develop health equity community metrics, proxies for health equity that we can use to really sort of keep tabs on what's going on. The other piece in working on community health needs assessments and community health action plans, hospitals are required in the U.S. Through the IRS to develop community health needs assessments and then community health action plans. So each nonprofit hospital. Often the ideal situation is for health departments to work with those hospitals and those health systems in developing them so that they can coordinate and align their community health needs assessments, as well as the questions they do, the process they take, as well as the community health action plans. So that would be another interesting thing to do, is to then triangulate over into what hospitals are doing in those communities, and if they are aligned, if they have similar goals and similar benchmarks as the health departments. In terms of the per capita spending by the health department, given the extensive research that shows that it is in fact social services that make the biggest impact on health status, it would be interesting to see not just health department spending, but look at the social services departments of local government and see how much they spend and if they coordinate or work with the health department. Similarly, in that vein, to look at what policies exist within local governments or state governments, but to look at if they use anything like health and health policies or health impact assessments, if they have ways of having interdisciplinary teams between the health department and the social service and education, transportation and housing. So really looking at how are they operationalizing addressing social determinants of health, and what kind of funding is provided to both the collaboration as well as to each of those departments. I'd also be interested in finding out, as you looked at poverty, and as Bernie noted, the inverse relationship between the percentage of poverty and the efforts that you were looking at communities of color, percentage of communities where there are communities of color, and what the relationship is with that. I fear that you might find something similar to what you found with poverty. I'm also interested, having served on a board of health, what kind of data collection the health department undertakes. And are they collecting data by race, ethnicity, language spoken at home, sexual orientation, immigration status, disability status, and other health equity data collection markers that might help us delve a little bit more into the granularity of health equity. Finally, I couldn't help but think about the importance of leadership and advocacy and understanding the political aspects of policy as you were speaking. Where there's the greatest need, it seems that your research is indicating that we have made the least efforts, the tools that we could be using in public health. So I think this, in terms of lessons learned and recommendations or thinking about policy implications, there's definite implications for public health education and also the accreditation service process in terms of the need for leadership and advocacy and an understanding of the political process. But I'm very pleased to be part of this webinar and really excited to see your work. I would love to see, like I said, some qualitative aspects to supplement what you've done and maybe look at some policy recommendations.
Perfect. Thank you so much, Bernie and Gabriela, for commenting. And I agree. The interesting finding was the percent of population below poverty and that negative inverse relationship. and we do have to look into the resources and what's the presence of public health. Gabriela, when you mentioned doing a qualitative aspect, it's interesting because this was part of my doctoral work, and coming here to Kentucky to work on the NLSPHS survey, I would, based on these findings, I go back and actually do my qualitative on the Canadian public health managers, and it hasn't been worked out yet, but that was my hope and my intention, and it would make for a very interesting dialogue and findings and merging both quantitative and qualitative data. I loved all the comments that you made in terms of how we should delve deeper into what is the construction of the Board of Health, who's serving on it, and does that affect the level of health equity and public health performance activities done. And based on your suggestions, there would be several studies I can do and would love to conduct in the future as well. But I definitely have written it all down, and in the future would love to do more of these types of analyses. And I do have a whole academic career, so they will be done.
Thank you, Phuc. And I would like to start encouraging people to type in their questions. If you have any questions for Phuc, or even to the commentators too as well, you could type them down in the lower left-hand side of the chat box you find in the screen. So I guess to just start the ball rolling, Phuc, what findings do you find most interesting and why?
Yeah, the finding that I found the most interesting was definitely when I analyzed the percent of population below poverty, it's the inverse relationship. And as the commentators have mentioned, that is a very interesting finding. And to delve much deeper into that in terms of what is causing that, and that's probably where the qualitative aspect can speak more to, as well as perhaps even linking it with communities of color, like Gabriela has mentioned, and see what results you get from there as well. So that would be an area that I would love to delve much deeper into and really get into the health equity aspect of it.
Great. So now we have some questions from the audience. Krista asked, did you use population size for local health jurisdiction as a variable in your analysis?
Did I use population size for local health jurisdiction? Well, the population variable that I used was used for the expenditure per capita variable. So that's where I took the expenditure in the current years and divided by the population of the jurisdiction. So
okay.
I'm not too sure.
So it was incorporated into the model already, essentially.
Yeah, it was already included.
Selena asks, what are the biggest difference you see in public health between Canada and the United States in terms of equity-informed practice?
I think the biggest difference is, I think in public health in general, we do similar work in health equity, and we have that as the main objective in both the U.S. and Canada. What I find that is very different is in BC, where I'm based for my PhD, we have also a focus on Aboriginal health, and whereas I find in the States it's more of the racial makeup, and those are more of the comparisons. And tribal health is obviously of concern, is research here as well, but I don't see as much of it to the extent that we do at the University of Victoria, where we have a Center for Aboriginal Health Research. So that's the main difference I can see.
So Jeanette asks, or comments, and maybe you want to respond to this comment, I wonder if the public health expert, quote-unquote, mentality gets in the way of engaging low-income populations. We are getting a lot of pushback on the notion that the community members have wisdom or expertise. Another speculation is that public health professionals have a difficult time connecting with populations they perceive as being different from them. Do you want to respond to that comment?
I do. I'm sure there is there may be the public health expert mentality, but I think that's the importance of working with the communities and really building and establishing those relationships before the research takes place. I know for our team at UVic, we've established the relationships with the health authorities for years and have been quite successful in garnering their interest and being involved in the renewal of public health systems and the equity lens and public health projects. And we also have, for equity lens and public health projects, 2 meetings during the year and face-to-face with our knowledge users, where we share the research and the results that we have, and they provide us with more feedback. So that has always been a very good way of going about it.
Yeah, would our commentators also feel free to respond to that too as well? Bernie or Gabriela, feel free to also respond to the questions.
Sure. This is Bernie. This is a really, really important and insightful comment. We recognize, and I'm going to talk first about our research and then public health. In our research, we really realize that if we're going to affect health equity, we need to work directly with communities of people. So a lot of my work, apart from implementation in public health systems and services, is directly working with communities of people that are either affected by substance use, so wide range of substance use, overdoses, injection, drug use, harms, and so on, and communities of people that are affected by homelessness. And what I find is exactly what you have put in your comments in regards to who's the expert. And I think that we have yet to recognize the practical wisdom that communities have within our public health systems. And I'm speaking here from my experience in British Columbia. And, you know, the fact that public health at its very roots and its very core, you know, in functions like community development, are really focused on working with and bringing forth not their expert wisdom, but the practical wisdom of people in the communities, and particularly those who are affected by health inequities. So the absolute critical importance in that work of reflecting on of public health professionals reflecting on not only their expertise, but their own power, and the power that they have to support the voices of communities, to bring forward that kind of practical wisdom. And I was very struck recently by hearing Jenny Poppe from the UK speak, and you know, she really has brought that forth in the UK context and public health, and you know, supported it with philosophers like Aristotle and Martha Nussbaum, who would really say that any kind of we can have lots of knowledge, but the real understanding of that knowledge is how it's lived in the everyday. And I'm certainly not quoting very articulately verbatim, but the fact that that knowledge has meaning and is given meaning by how it is lived. And so in terms of the second part of your question, I would say yes. And I see it almost daily, if not, or see it weekly, if not daily in my own work, where public health is actually rather disconnected at many times. And again, I'm speaking about, my context. It may be different in yours. But I think when you have someone, and I'll take probably what's a very extreme example, Victoria over the last 7 months has been home to a tent city, a group of people who do not have any type of housing. We have a very low vacancy rate. We don't have really very much affordable, accessible housing. And I think, what I see here a group of people who are experiencing health inequities, who are, there are many, many, many areas of important work in relation to the determinants of health, but to connect with and to engage with and to support and bring forth that practical wisdom is actually not an easy task, and it requires a lot of skill and expertise on the part of public health practitioners. So, I've taken there is a lot to say actually about how to connect and what that connecting looks like, but it has to start with reflection on one's own power and one's own position, and sometimes taking an unpopular position when communities are reacting in very stigmatizing ways. So thank you for the opportunity to comment on that, and I look forward to what others say.
So Jeanette, just to add more context also to her comment, she was talking also about the context of, when local public health departments conduct a community health assessment and community health improvement plan. I guess since we've been also talking about health equity, you did mention, Phuc, that there were limits, one of the limitations was the lack of health equity variables in all 4 waves. What are some of the health equity variables you're thinking or you'd like to include in your analysis moving forward?
Yeah, I was thinking, there are more variables available in the 2 or 3 of the waves, but all 4 waves were the ones that were a little bit more limited. But I guess that's not too surprising because 3 data sets were also merged and the questionnaires change and evolve since the early years. But I would love to include in the analyses the race, socioeconomic status, employment, and see if those play a role as well in the analyses.
So, okay. There are more couple of comments coming in, and if we're sorry if we can't get to your questions, we'll always be able to forward that to our presenter today too as well. So even after the presentation, you feel free to get in touch with her or even here at the center, and we'll forward the questions. So one of the questions before, I guess the last 2 questions is Joe asked, are there published cost effectiveness or cost utility studies for health equity interventions that you're aware of, Phuc, or in your research when you did, I guess, the literature review?
It's not.
Come across?
I didn't come across any, but I also know that having done this work, this is the first that's been done using the data sets that we have on health equity. So I'm sure in the future more work will be exploring the cost effectiveness, especially specifically in health equity interventions.
So I guess you just mentioned the future. I guess we wrap it up there. Could you share a little more about, you did mention about the plans to maybe adapt the NLSPHS survey to Canada, and what can we expect moving forward? Could you share a little bit more about that, Phuc?
Yeah, so I know that we've been in talks with Dr. Mays to adapt the NLSPHS survey, and hopefully we'll have that done, hopefully in 2017, and then we'll do comparison studies from here on out. That's what I know so far, and I'm excited, and I'm excited to be involved and to see where this work takes us and really strengthen the cross-border public health services research that's being done.
So you did mention Dr. Mays. Dr. Mays, are you on the line? Would you care to respond or comment to what Phuc mentioned, or is this something that you guys have discussed already?
Sure, yeah. So again, thank you to our presenter and to our commenters today for a fantastic discussion. A couple of things I think to highlight. One is I think this work highlights the benefits specifically of pre-doctoral research funding opportunities, as we've had the chance to work with Phuc over the last 9 months here, and in particular the Fulbright mechanism. Maybe put in a plug for that. This is this is the mechanism that Phuc has used to spend time with us here at our research center, and to really get a jump start into her dissertation work. This is all pre-dissertation work that Phuc has been able to work on over the last 9 months. And so I would encourage all of us who work in the public health research world to think about these kind of opportunities for international research collaboration, because that's what Fulbright's all about. In particular, how it can benefit early career stage, even pre-doctoral scholars, as we've just heard from today. It's been a great experience from my perspective in being able to work with Phuc over the last 9 months, and it's strengthened our relationship, I think, with our colleagues at University of Victoria, and helping us think more expansively about opportunities for cross-national comparative research in public health. So a lot of opportunities that we'll be exploring as that work moves forward. Now, and again, I would just encourage all of us who work in the public health research world in the U.S. I think we too often get so focused on just dealing with the heterogeneity that we see within public health, just within our own states and national context. But if we start to look across borders, there are even still more different kinds of models for organization and financing and governance and health equity that don't exist in nature here in the U.S. And it's only through cross-national collaboration and comparative research can we take advantage of those kind of opportunities. So we're going to continue to build on the relationship we have with colleagues at UVic, and to capitalize on opportunities for Canadian-U.S. work, and I think there's lots of other similar kind of opportunities globally as we think about meeting the global challenges of public health improvement. So thank you again, Phuc, for your great work.
Thank you, Dr. Mays. And Pho, any last words? I guess not. So, Pho?
Oh, yes. Sorry, I was on mute. Thank you to everyone on both research teams for supporting this work. Here at Systems for Action, and as well as my UVic team, having the experts, Dr. Mays, Dr. Bernie, Pauly, and Dr. Marjorie McDonald, come together and really help shape my work and cross-collaborative work is one of those opportunities that you can't pass up, and as every doctoral student, they look forward to. And so I appreciate everyone for taking me in and taking me under their wings and just teaching me all that I need to know to continue with my work. Thank you.
So with that, we'd like to thank you, Pho, for your presentation. We'd like to thank also your commentators, Bernie and Gabriela. Thank you so much for being able to participate in this webinar today. And we'd also like to thank all our audience members too as well for participating today, and we'd like to welcome you and let you know of upcoming webinars in this PHSR webinar in Research in Progress series. So we have one on June 1, so we'd like to invite you to that. And for previous webinars too that you may have missed, you can also look that up. We have an archive of those presentations too as well. And anyone else from the center would like to add anything more before we wrap up? I guess if not, we'd like to thank you again, everyone, for joining us, and we're giving you back 5 minutes of your day, and thank you so much again for joining us, and have a great day. Goodbye. Thank you.
Thank you. Bye.